When most people think of heart disease, I get the feeling they think of someone who's older, maybe a little bit overweight, maybe already symptomatic, experiencing chest pain, perhaps on exertion. But you've spent your career trying to shift that narrative. Can you paint us a picture? What does early heart disease actually look like? And why is this a topic that you're so passionate about?
So this is a great place to start. I've dedicated my professional career to cardiovascular disease prevention. And prevention really, I often say, begins at the moment of birth. In many ways, prevention should begin before the moment of birth because the risk for vascular disease and cardiovascular disease really starts in the womb. And it is a process that is occurring across the life course. And you started off by saying, we often have this picture of the person with heart disease as an older person, way back when we would say an older man. And we know this is not the truth. Heart disease is an equal opportunity killer, the number one cause of death in men and women. And heart disease begins at a very early point in time. And when we talk about heart disease, today I think we're going to be focusing predominantly on vascular disease because heart disease is a kind of broader category, and the heart itself can have problems at every part of the cardiac anatomy, physiology, and even the electrical system of the heart. We do know that prevention should start at an early point in time. And we, as cardiologists and as preventive cardiologists, often are seeing people with heart disease at a younger age. In fact, we know that in 2/3 of the counties of the United States, we are seeing deaths from heart attacks and strokes at an earlier point in time. Now, I know from your background and your passion equally focused on health promotion and disease prevention, that some of that was initiated because your father had had a heart attack at age 41. Would like to hear more about that because I think it'll be an important core for our discussion today. Similarly, my commitment to heart disease prevention started at an early point in time. My grandfather on my mother's side, my maternal grandfather, had heart problems at a young age in his late 40s. And he died way too young at age 62. And so even as a teenager, my interest at an early point in time was in the heart. And as I was going through my training, we were at a point in time where we were starting to really understand the science of heart disease. I thought ahead and said, the future is in cardiovascular disease prevention. My training has spanned from molecular and vascular biology. I'm a clinical cardiologist, so I care for patients. I'm a teacher, I'm a researcher, but my career also has taken me into the realm of public health, population health, and global health. But maybe let's hear briefly just about your story and your father, because I want to use that as an anchor, because most of us, when we ask, does heart disease run in your family? The answer typically is yes, because globally, over the last 3 decades, heart disease has snuck up on us as the number one cause of death all across the world. Now even more so in low and middle income countries, but we have the equivalent of low and middle income countries in our own backyard here in the United States, in a city like Atlanta, New York, Los Angeles, Boston, Chicago, within a short radius of geography. And an example might be Atlanta. The northern part of Atlanta is called Buckhead. Driving distance might be 6 miles to Bankhead in the southwestern part of the city. And the difference in life expectancy is about 15 years now. And a lot of this is related to heart and vascular disease. deaths prematurely. So let me stop there because I do want to hear about, you and your father, and want to use, heart disease prevention as the core of our discussion today.
Yeah, and I wonder, how common my dad's experience is today, because this is now going back over 20 years at this point. And my dad experienced a heart attack, as you said, at age 41. And he wasn't someone who had a diagnosis of heart disease. He wasn't someone that was taking lipid-lowering medications or medications to lower blood pressure. So for him, it came out of the blue. And that's an interesting thing for us to think about here. How many is that common today? And are people walking around with undiagnosed heart disease with risk factors that are not identified due to whatever reasons, lack of screening or awareness, education, socioeconomic status, healthcare access, these sorts of things? Is that common today, or have we made huge amounts of progress there?
I think we've made significant progress in the science, in the understanding of cardiovascular disease and cardiovascular disease risk factors. We've made huge progress in the capabilities of preventing, and we've made really significant strides in the capabilities of treating once there is heart disease. Our biggest gaps, though, are in awareness, detection, and what we call implementation science. So your father's story remains very common today because heart disease is a silent process. We talk about the timeline of atherosclerosis, and what we're going to be talking about heart and blood vessel disease today. I know you've had many speakers on before or guests talking about atherosclerosis, but the atherosclerotic disease process, often begins at an early point in time. We can see this process beginning as early as ages, 2 to 4 to 6 to 8. We see measurable disease in teenagers, and we know from some classic stories and classic studies looking at Korean War veterans, studies like the Cardia study that has followed population of young individuals for decades, that the measurable nuances and the seeds of cardiovascular disease are beginning at an early point in time. So it's very much important that we focus on upstream ability to prevent. That's the public health piece. But then primordial prevention, that's what begins before the moment of birth and at the moment of birth for an individual, a family, a community. Primary prevention, when a person has at least identified cardiac risk factors like high blood pressure, cholesterol abnormalities, pre-diabetes. And then secondary prevention is when the cat is out of the bag. Somebody has, diagnosed heart disease at each and every stage. Thankfully, we can make a significant difference if we focus on that comprehensive cardiovascular risk reduction.
How much of atherosclerosis would you say, if any at all, is an inevitable part of aging as a human being? So, our biology and the genes and what we've inherited, the selection pressure from an evolutionary perspective is geared around getting to an age to procreate and to, essentially bring new life. And then after that, do our genes really care about whether we're developing atherosclerosis in our 40s or 50s? Perhaps not. When you kind of think about this process of laying down plaque, how much do you think is explained by our genes and just what we've inherited versus the lifestyle and the choices we're making?
Yeah, so great question. This disease process is a gene, environment, behavior interaction. 100% of human beings carry the genes for hypertension. Depends on the population, but anywhere between 1/3 and 2/3 of the population carry the genes for diabetes. There's also, we'll talk later about the exposome, but this is, exposure over time to various factors. They can be internal. Our microbiome can become disrupted, but exposure over time to external factors, our local environment, the air we breathe, the water we utilize. But the process of atherosclerosis is not a normal part of aging. It is a common part of aging. And if we begin to look under the hood at various time points in populations, we will see what I call subclinical atherosclerosis. We can measure that through, ultrasounds of the arteries in the neck, measures of vascular function or vascular dysfunction. We can measure it by looking at coronary artery calcification on imaging like CT. If we look, though, at atherosclerosis, we have a gene environment behavior exposome mismatch. What do I mean by that? Well, our genes have not moved a whole lot for the past thousands of years, but our environment has changed dramatically in the past 100 years. An interesting question, though, and we're in the midst of putting a paper together about this, is atherosclerosis has been discovered in mummies. And most of the populations around the world that have been studied, there are a few populations that appear to be very protected from atherosclerosis, whether that's a combination of their genes. They're often a population that has not been exposed to Western lifestyles and behaviors. So probably good genes, but, healthy behaviors. But we've asked the question, and Greg Thomas at the University of California, San Diego, has really been a pioneer in this mummy atherosclerosis question. And we're working with Greg and his team on a very interesting and provocative paper. But why would people, thousands of years ago, when they didn't have the Western environment, why would they develop atherosclerosis? The biology of atherosclerosis, originally we thought it was a response to injury, originally described by Russell Ross. We think it's now more complicated than that, but our blood vessels are an incredible network. And I may not have this exactly correct, but if we stretched our blood vessels from the largest blood vessels, our aorta, all the way down to the smaller blood vessels, and then the microcirculation and the capillaries, for each and every one of us, this would span about 60,000 miles. And our blood vessels encompass 6,000 square meters, so very extensive. But getting back to the mummies, the thought is that many things can incite injury and inflammation of blood vessels. And that can be infectious diseases. And so, thousands of years ago, when human beings, didn't live to age 90 or 100, they were carrying many infectious agents causing chronic low-level inflammation, and also the chronic stressors that were occurring, famine, lack of water, the stresses of being a human being, and just in survival mode most of the time. So atherosclerosis is not a new disease, but we've created a new form of atherosclerosis, as I mentioned, seeing this disease starting at an earlier and earlier point in time. It often is not manifest until there's some acute process. And that acute process can be a heart attack, a stroke, can be somebody developing new symptoms because the disease often is very silent and it is percolating in our blood vessels, but can be prevented and can be detected at an earlier point in time.
What are some of those other earlier symptoms that someone might experience outside of the big events like having a heart attack or a stroke?
Yeah, I think it's important to not wait for symptoms. As we optimize a strategy for prevention, we should be preventing on a population level. And so this means focusing on making the healthy choice the easy choice for populations. This can begin and should begin in our schools, should begin in our communities, and creating opportunities for predominantly plant-based, whole food dietary patterns, regular moderate physical activity that is safe, because there are many areas and communities where you can't walk safely in the community. Certainly promoting tobacco cessation in those that are smoking, but more importantly, promoting not beginning any tobacco products at a young point in time. But as opposed to waiting for symptoms, and I'll talk about the symptoms in a minute, we want to risk assess individuals, certainly in young adulthood. Every American aged 20 and above should have a cardiac risk assessment at least once every 5 years. They should have a cholesterol measurement at least once every 5 years. They should be aware of their blood pressure, because we see elevated blood pressure in children and young adults, and this has a cumulative effect. We see prediabetes now in 6 to 8-year-olds, type 2 diabetes, not type 1, which is, we used to call that adult onset diabetes. But when we start the ticking clock, I wrote an editorial for the Journal of the American College of Cardiology talking about the ticking clock. And when these genes get activated like a switch, the clock starts ticking. And imagine when the clock starts ticking in a 6 to 8-year-old child, that clock will tick, tick, tick silently for decades until disease either becomes manifest. So we come back to symptoms, classic symptoms, some degree of exertional chest discomfort, tightness, and uncomfortable feeling in the throat, the arm, the shoulder. The word angina, first described by Heberden, is of the throat or to strangle. And interestingly, when Heberden first described angina, he described the observation of what occurred to people who developed angina, but he never used the word the heart once in his original description. People can experience change in their exertional capacity, symptoms of shortness of breath with activity, but we don't want to wait for those symptoms. And so that comes back to cardiovascular health promotion and disease prevention. The American Heart Association has described the characteristics associated with cardiovascular health as opposed to cardiovascular disease. This is called Life's Essential 8. These are 8 factors that predict cardiovascular health as opposed to cardiovascular disease. 4 of these factors are lifestyle and behavioral, so smoking, dietary pattern, physical activity, and then the new factor is sleep. And then 4, we'll call these measurable biologic factors: your cholesterol, your blood pressure, your blood glucose, and then your waist circumference or your BMI. People who have none of these risk factors, or let's just say all of these Life's Essential 8, it is a significant predictor of cardiovascular health when measured even in young adulthood or middle-aged. And these people will often go on to live a healthy life without significant cardiovascular disease risk. Sadly, though, when we look at the American population, we published this paper a number of months ago looking at the National Health and Nutritional Survey, focused on a construct called the CKM initiative, Cardiovascular Kidney Metabolic Health Initiative. And we looked at data, several cycles of the National Health and Nutritional Survey, and we described that even in young adults in their 20s to 40s, 80% of them have some of these heart risk factors already. And above age 65, only 2% of Americans have no risk for cardiovascular kidney metabolic disease.
Okay, there's quite a few threads to pull on there. Coming back to the statement you made about making the healthy choice the easy choice, which gets me thinking about populations, areas of the world where people have great health span and great longevity. And one of the key differences being the environment that they find themselves in, that they've grown up in. And I often get asked, whether willpower is required to be healthy. And at least my answer to date and how I think about this is that I do think when you live in the Western environment that we find ourselves in right now, where we live in this environment where the healthy choice is not always the easiest and most convenient and cheapest choice, I think there's an element of privilege to being healthy for sure. And then also it requires a degree of intentionality because our environment is very much like a maze. It makes it a little bit tricky to get to the center of that maze to find health. And so you need some intention to kind of say, yeah, turn right here, turn left there, turn right. And you can find your way through that maze if you have all of the right information and kind of whispers over your shoulder. Whereas the environment that some of these long-living populations live in, it's more like a labyrinth. There is only one way to the center. And I think that is a nice way of just thinking about our current environment. And I share that sentiment with you that our environment and the way our cities are set up and policy will very much inform that, needs to shift to really address some of these risk factors at large, particularly for areas of the population that don't have the means, the education, the resources that more privileged populations do to even just engage in this conversation, to listen to this podcast right now and to act on it.
So I'm really glad that you're bringing this up. This is something we often don't recognize when we speak about cardiovascular disease prevention. We talk about risk factors and behaviors and assessing risk, and then we try to individualize it like, Mr. Smith or Mrs. Green. This might be a clinic encounter with a usual clinician. You're a little overweight, you have prediabetes, your blood pressure is slightly high, your good cholesterol is lower than we'd like, your triglycerides are up a little bit. You're heading towards some concerning health issues if we don't get a handle on this. So I think it would be a good idea to eat better, exercise more, lose weight, and here are some handouts. And we'll see you back in 6 months and see where we are at that point in time. And a lot of this has to do with that knowledge or privilege often is not enough. I've had patients who have a PhD in nutrition who could write the textbook, but yet they themselves on a behavioral basis or just, challenges with their day-to-day life or environment, they themselves are overweight and very unhealthy. You talked about where we're born, just place of birth determines a lot for us. And there are areas around the world called blue zones. I'm sure you're familiar with these. And the blue zones have a lot of commonality. And vertical living is a part of living in a blue zone. It's not just moving more, but moving more up and down. Having a supportive community is part of a blue zone. Of course, sustainable foods that are coming from the environment in which you live. I served for 5 years as the executive director of the Million Hearts Initiative for the United States, a CDC CMS initiative that really captures a lot of this. And it's an initiative focused on the possibility. I call it an example of possibilism, that we have the knowledge, tools, and resources to prevent 1 million heart attacks, strokes, and cardiac events in the United States in a 5-year cycle through building healthy communities, optimizing care, and then a core focus on health equity, because where we're born and how we live are not equal. Making that healthy choice, the easy choice, is creating walkable, safe environments, but also building the opportunity for healthier foods and healthier food choices in our schools, in our workplaces, and also recognizing that health promotion and disease prevention should be our primary focus, as opposed to waiting for a disease state that, once you have hypertension, hypercholesterolemia, prediabetes, we can treat all of these issues, and we can prevent at a high degree. But we often miss out on the first part of the life course, and the injury of these blood vessels, the development of inflammation. So that public health piece is key. The risk factors, though, are very common. And we often are waiting to make the diagnosis of a risk factor often too late, let alone the diagnosis of symptoms too late or a disease too late. Let's talk about cholesterol. 1 out of every 250 people in the world have a genetic cholesterol disorder called familial hypercholesterolemia. My current position is the Chief Medical Officer of the Family Heart Foundation, in addition to the work I do as a professor at Emory University School of Medicine, our School of Public Health. When you're born with a cholesterol level that is 2, 3, 4, 5, or sometimes 8 times above the upper limits of normal, that exposure begins in utero at birth. And I was definitely not a math major. The only thing I remember from calculus is the integral. That's the area under the curve. Exposure over time. This is how risk factors exert their risk for vascular disease. But if we think about the flip side, the reduction of risk factors and that area under the curve over time leads to cumulative preventive strategies.
I recently swapped my late morning coffee for something new, Nandaka from Peak. And I have to say, friends, I've been genuinely impressed. With Nandaka, you still get that smooth lift in energy and focus, but without the crash or that wired feeling that often comes with coffee. And yeah, I was skeptical too, but this is not your average coffee alternative. It's truly been a real upgrade for me, helping me drop into a focused flow in afternoons when I'm reading, writing, or prepping for episodes here in my office. What sets Nandaka apart is the attention to detail. Cacao butter for better absorption and triple toxin screening for purity. It's made with 100% fruiting body mushrooms, ceremonial grade cacao, and fermented tea. No fillers and no grainy mycelium. We love a thoughtful formulation here at The Proof. Right now, Peak is offering 20% off for life, plus a free starter kit. That's a rechargeable frother and glass beaker with your purchase. And there's a 90-day money-back guarantee, so you can try Nandaka risk-free. Just head to peaklifecom/Simon. That's PIQUE life.com/Simon. I'm not sure if you saw, it was about 2 or 3 weeks ago, maybe a month ago, a paper was published looking at folks that adopted a ketogenic, so a high-fat diet. It's called the Keto CTA trial. And they were interested in following these subjects who had very high LDL cholesterol and ApoB doing a CT angiogram and coronary artery calcium scan at baseline and then following them for 12 months. And the hypothesis, or at least of some of the authors involved, was that this group was potentially not at a high risk for plaque progression because they were considered otherwise healthy. They had, a healthy HDL cholesterol and triglyceride level and healthy body weight and these sorts of things. And it's been interesting to watch the aftermath of that, because there's been a number of letters to the editor following that article with people looking at the actual rate of progression. And it seems that these folks, even though they have those other risk factors in what would be described as a healthy range, did in fact have much more rapid plaque progression compared to healthy subjects, at least from other studies, which is not a perfect comparison, but this was not a randomized clinical trial, so there was no control group. So it's kind of the best you can do with the data at this point. But did you see that study, and do you have any comments on that?
Did see the study. Of course, we often hear in the news, what might be the latest health news blurb. And of course, there are many of these out there. Many of them are connected to cardiovascular disease prevention. There's a concept called metabolically healthy obesity. And, there are camps out there trying to make the case that you can be metabolically healthy and obese. It's because those people haven't been followed long enough. Obesity over time is not a healthy state for our body. And a ketogenic dietary pattern, and we've written some about this, there's no state in the human body when you're in ketosis that is a healthy state. So a ketogenic dietary pattern can promote a very high cholesterol level, not in all, in some, but ketosis, some of the theory is, of course, you're stressing the body with ketosis, and then you're developing, response to that stress and some resilience. But it doesn't surprise me the findings of that study, that a ketogenic dietary pattern can be vascular promoting. When I have patients ask me about a very low carb ketogenic dietary pattern, it gives me an opportunity to speak with them about a healthy low carbohydrate dietary pattern, but not the classic ketogenic diet where you have bacon and eggs without the toast for breakfast, the hamburger without the bun for lunch, and then the steak without the potatoes for dinner. Our blood vessels, we used to think were inert, like pipes. And the pipes would eventually build up enough plaque and sludge, and then we'd either have symptoms or some event. Well, from a molecular and vascular biology standpoint, we know that our blood vessels are very dynamic. There's a single layer of blood vessels lining, a single layer of cells lining our blood vessels called the endothelium, a middle layer, the media, and then the adventitia. But the blood vessels are monitoring our environment really in a very dynamic way, and they are very responsive to our environments. A colleague of mine, Michael Miller, who used to be at the University of Maryland, now at the University of Pennsylvania, he published studies, it's been easily 15, 20 years ago, but he took healthy volunteers, measured their endothelial function by looking at the brachial arteries in the arm, and then took these young volunteers and took them to a fast food restaurant and fed them the greasy breakfast special. And within a few hours, those arteries demonstrated findings of vascular dysfunction. Those arteries were essentially cringing. He also took healthy volunteers and did a crossover trial where he had them watch a comedy and then Saving Private Ryan, a very stressful movie. And so our arteries are reacting to what we eat, what we do. Physical activity promotes high levels of nitric oxide, but also our arteries are responding to our internal stress, the air we breathe. So let's go back to the breakfast special and now think about the diets of many children, teenagers, young adults. If those arteries are cringing each and every time they're eating, foods that are not heart healthy, this has a cumulative effect: injury, inflammation, and then the arterial walls start becoming diseased, dysfunctional. And we know that I call cholesterol permissive. You have to have a certain level of a cholesterol abnormality to develop the disease, the classic disease, atherosclerosis. There are other ways of developing artery problems, like radiation, for instance, can injure the wall. But in order to develop atherosclerosis, you have to have your cholesterol level be elevated. Now, elevated is not an LDL cholesterol of 200 milligrams per deciliter. It might be just having an LDL cholesterol of 100 milligrams per deciliter with other factors that are additive.
Right. So the cholesterol component is necessary for the development of atherosclerosis, but these other factors, damage to the artery wall from hypertension or the foods we're eating or not eating, is making you more susceptible to those particles that are carrying cholesterol entering the artery wall in the first place and becoming retained and kickstarting that atherosclerotic cascade. Is that how you see it?
Yeah. So we talk about response to injury. Then there's retention, as you describe it, of oxidized LDL cholesterol being incorporated into monocytes. There's a whole vascular cascade that's occurring with cytokines, smooth muscle cells, platelets, and this disease is kind of waxing and waning, off and on, off and on. And one of my goals as a preventive cardiologist is, I think of it like I mentioned earlier, that light switch where we can turn our genes on and off. The disease atherosclerosis, is a disease that we can turn off. It's a very complex disease, though, so we don't have a single magic bullet. But once we turn that disease off, we can cause disease regression, lack of progression, and even patients that come to me, with significant subclinical atherosclerosis, they might have had a cardiac CT calcium score with a score of, let's just pick a number, 250. That puts them in the 90th percentile for age, gender, and ethnicity. We often develop a plan together because my goal is that person will live a long health span, not just a lifespan, never having an atherosclerotic event. And today in 2025, this can happen.
So they'll die with atherosclerosis, but not because of it.
Absolutely. Atherosclerosis, once we begin to shrink the plaque and heal the plaque, we can, through a multi-pronged approach, but we have to be very specific and also very thorough in how we address that disease for an individual. We come back to the willingness of choice. But there are many other factors that can contribute to the disease. Secondary tobacco exposure, the air we breathe, particulate matter. In the country of India, the air that is being breathed has become a greater risk factor for heart and blood vessel disease than smoking. And so even in somebody who is aware of their family history, is aware of their risk factors, is being proactive to be healthy in their behaviors, is addressing those risk factors, they can't necessarily control the air they're breathing in some of the cities there. So there are certain factors that are under our control to some degree, or especially in partnership with our physician or clinical team. But there are factors out there, this exposome, that I think we're learning more and more about, that are becoming very important. The air that's breathed and the environment is a really critically important factor for heart and blood vessel risk now, and it's quite concerning.
Is that something that you consider like within the bounds of your own home, or is this more a kind of conversation someone would have with regards to where they choose to live and the air quality in that city?
It can be within your own within your own home. Communities that are more rural often are cooking with a wood or coal-based stove. And so in the domains in which they live, they're getting exposure to particulate matter from within their own home. And we know from studies of individuals living in these communities that this exposure affects women and children more than men. Now, within our own home, we have the water we're using, the processed foods that we bring into our own home, because the environment in which we live today is, from a nutritional standpoint, has been very changed as we move from an agricultural society to an industrial society, and now a global society. Processed foods, packaged foods, foods that are non-nutritious but high caloric appear to be a significant contributor to the obesity epidemic, this pre-diabetes that leads to higher risks of heart and blood vessel disease, which, blood vessel disease, today we're talking about heart disease prevention, but our blood vessels, they extend all the way from the tip of our head to the tip of our toes. And so heart health and brain health, are very synergistic. Vascular health in general should be our overall focus.
What other conditions outside of vascular dementia or having a heart attack or having a stroke, what are the major conditions that people will have heard of or may have a diagnosis of involve vascular dysfunction?
Yeah, vascular dysfunction, if we go from our head to our toes, dementia clearly. We know that vascular health can affect our arteries in our neck. We call this peripheral arterial disease. So outside of the heart, the peripheral arteries can be affected. The arteries in the neck, the arteries in the major highway of our body, the aorta, which branches to our kidneys, to our legs. These can be manifestations, but so can smaller blood vessel disease that can begin to affect our kidneys, for instance. We know that microalbuminuria is an early sign of injuries to the kidney apparatus. And this can be detectable by a simple test, a urine albumin creatinine ratio, yet this simple test is frequently not done. It's part of the construct of the Prevent Risk Calculator that was developed by the American Heart Association and really is now being adopted as probably the most up-to-date way of thinking about the totality of our vascular health. It brings together the risk factors that we've known well since Framingham: age, gender, smoking, blood pressure, cholesterol, diabetes. Interestingly, family history is not part of many risk calculators, although we should be asking about a detailed family history. But the Prevent Risk Score brings in measures of metabolic health. Our BMI, it is imperfect BMI, but in a population, it is a predictor of cardiometabolic risk. Probably better waist circumference or visceral adiposity might be a better measure. but it also brings in an A1C, urine albumin creatinine ratio, but a really important part of the prevent risk calculator, which I was part of the team that helped to develop, derive, and validate, is that race and ethnicity is no longer part of this calculator. We use zip code in the US as a surrogate for the social deprivation index. You mentioned this earlier about the social drivers of health. These are equally important for many: access to healthy foods, transportation, again, our environments in which we live, education, income. These are determining a lot today in who are most vulnerable for chronic diseases at an earlier point in time.
You mentioned earlier that atherosclerosis can effectively, it's something that we can turn off. So if we're zooming right out and thinking about, there's probably people listening, I'm sure everyone thinking, well, Laurence, I'd love to turn this process off. And then also thinking about the fact that the necessary component is cholesterol. Is addressing ApoB and or LDL cholesterol, and you can perhaps remind people of the difference and kind of overlap between the two of those, is addressing that and optimizing that, is that part of the cardiac risk assessment that you mentioned? And is that ground zero? If you get on top of that and optimize it, but still have some of these other risk factors in play, are you still going a long way to stopping progression of atherosclerosis?
Yeah, so here I'll start at 30,000 feet. Our LDL cholesterol, a low-density lipoprotein cholesterol, is a concentration of cholesterol in our blood being carried by particles. These are particles that are certainly necessary for the development of atherosclerosis. In a very simplistic way, I teach people that the LDL cholesterol is the lousy cholesterol that you want lower, the HDL, the healthy cholesterol that you want higher. Although this is a very basic concept, we were one of the first in the world to publish the concept of a U-shaped curve with HDL cholesterol. So your HDL is probably more of a marker of risk. It can be low and a marker of risk, but it can be high in some people and be dysfunctional. The HDL is not doing the job of the HDL with reverse cholesterol transport, taking the cholesterol out of the blood. Now, LDL is a pretty basic measure, but I think it's the right initial measure, and I am a purist. As part of that risk assessment, if you plug into what we call the pool cohort equation, or now the prevent risk calculator, LDL cholesterol is not one of the variables in the calculator. It's total cholesterol and HDL, but LDL is accounted for as part of the totality of the atherogenic particles. I know you've had some guests on before talking about ApoB, and ApoB might be we might call it the gold standard, because the apolipoprotein B, the ApoB 100, is the carrier protein for the atherogenic particles, and there's a one-to-one relationship. So ApoB, I think, is worth considering. You can measure particle number, but I'm going to come back to a pretty basic concept called the non-HDL cholesterol, and many people have never heard of non-HDL. In fact, next week I'll be starting as the attending on our hospital teaching rounds. And this is one of the questions I often ask on rounds. So if some of our students or residents or fellows are listening, they might have a heads up for my question on rounds next week. I often ask about the non-HDL, and people say, what? Well, the non-HDL is a pretty simple equation. Total cholesterol minus HDL is the non-HDL. And I think it's confusing because whenever we talk about a non, it becomes just a confusing concept. But that non-HDL encompasses all of the atherogenic particles. So the LDL cholesterol, the intermediary cholesterol particles that can be atherogenic when repeatedly circulating in our blood, and the lipoprotein little a, which we'll come back to, because I think LP little a is an area that is science in the making that's been in progress now for 6 decades. So I'm a fan of using the LDL as a starter, then the non-HDL. And we wrote a paper titled Do the Math, because at least as a clinician, if you graduated from first grade, you should be able to calculate non-HDL. And the other point we made in our paper is, from a health economic standpoint, this is the cost of a non-HDL after the LDL. It's $0.00. Now, ApoB, if every single clinician ordered ApoBs on each and every one of their patients, there's incremental cost, and there's, I would call it, sometimes value, but sometimes not value.
Right. So non-HDL, it's accessible. It's either on a standard blood panel or it's easily calculated. And in most cases, it approximates ApoB, or does a very good job at approximating ApoB, in that it's adding up the amount of cholesterol across all of the ApoB-containing lipoproteins.
ApoB is valuable when there's a concept called discordance. There can be some people that have a normal LDL or an LDL in the range of, where we wouldn't be as worried about it, but their ApoB can be elevated, or the non-HDL can be elevated, or the particle number can be elevated, and we can miss the boat, both clinically, but also we can miss the boat in terms of cardiac risk. And then once we begin treatments to lower the cholesterol, especially when we're reducing the cholesterol to a very low level, we often, if we're just using the LDL cholesterol, we can underappreciate this residual lipid risk. The lipids, can you turn the switch of lipids off? And that's the magic bullet. And the answer is, we do think lower is better for longer. And I often get asked, well, can your cholesterol be too low? And there, evolutionarily, what we know now from scientific studies is probably 0 might be too low, but frequently I see patients that I care for that have established heart disease that are on a combination of very potent agents to reduce their cholesterol, and their LDL cholesterol might be under 10 milligrams per deciliter. So I think central to turning the switch off, the heart of heart disease prevention is in lipids, but that's not the total game. Hypertension, from a population attributable risk standpoint, hypertension affects more people than hypercholesterolemia, and we often negate mildly elevated blood pressures for many decades that are having impact over time.
Is hypertension still causing vascular damage aside from its effect on ApoB containing lipoproteins and making the sort of artery wall more susceptible to these passing through and becoming retained? So in other words, if you optimize ApoB to a level where it's very low and you're not getting a lot of these particles crossing over the artery wall anyway, is hypertension, high blood pressure above what's normal, still a problem when it comes to vascular health?
Yeah, I think with hypertension, there are physical forces involved, repeated injury not only to the large blood vessels, but to the small blood vessels in the brain, the heart, the kidneys, the vasculature in general. So I think vascular injury is possible with hypertension, but atherosclerosis, realizing that a very low LDL is needed to prevent the development of atherosclerosis over time, that LDL, I think, is necessary, as you phrased it, or permissive, as I said. But we know that even people with low cholesterol levels, with hypertension, who are smokers, can develop vascular events, because a low cholesterol level, most people ambiently, don't have LDL cholesterols of 30 milligrams per deciliter. That's you have a genetic condition that might be protective from atherosclerosis, hypoapolipoprotein beta. But most humans are not, living with that genetic condition. In fact, optimal levels, we used to say, optimal levels keep getting lower and lower. For blood pressure, many decades ago, we would say it's essential to have a certain level of blood pressure to perfuse your brain and vital organs. And the definition of blood pressure was 120 plus your age. Franklin Delano Roosevelt, when he was president, he died of a hemorrhagic stroke with blood pressures in the 200s and 240s. So we keep learning more and more that, normal or average is not optimal. The LDL, though, I think is a really key piece of this equation. But if it was as simple as LDL alone, I think atherosclerosis should be able to be abolished with LDL only therapies. And we still have residual risk in people when we're treating their lipids very aggressively.
Is that because they have a lifetime of plaque accumulation? Would that be different to someone who just has low LDL cholesterol from birth or from 10 years of age?
Yeah, I think that's part of it. We can't, despite the tools we have today to detect disease earlier, to address disease, and to prevent, we can't dial back to the day we were born. It's a question I get asked frequently is, you have a disease, can you make it go away? And I say, we don't have liquid Drano. We can't turn it back to the day you were born. And likely that exposure over time in the early part of your life is more important than the latter part of your life. And so you can't completely undo atherosclerotic risk. One of my colleagues at Emory, Peter Wilson, and Peter ran the Framingham Heart Study. He reminds me that when we do a risk calculation and come up with a risk of X over the next 10 years and Y over the next 30 years, and then we demonstrate to our patients by improving risk, by lifestyle and behavioral factors, by medications, we can significantly reduce risk. But that second calculation, although it's nice to talk about the theoretical reduction in risk, it is not entirely valid because it doesn't, come back to that area over the curve across the life course. We can't take the area under the curve for the first 30 years, 40 years, 50 years. We can't take that away.
Right. The exposure for blood pressure is the blood pressure level multiplied by the months or years that you've had that blood pressure. I've had a bunch of friends ask me recently, Simon, do you actually rate 8 Sleep? So here's the truth. I would not promote 8 Sleep if it hadn't genuinely helped me. It has literally transformed my sleep. Since adding the Pod 4 Ultra and then more recently the Pod 5 Ultra to my bed, I've been waking up feeling fresh, clear-headed, less inflamed in the face and fingers, and ready to take on the day with enthusiasm, rigor, kindness, and patience, all good things. That's what a proper night of recovery does. It literally makes me a better human. The Pod 5 isn't a mattress. It's a high-tech cover that fits over your existing bed. It personalizes the temperature on each side, tracks your sleep stages, and even detects snoring. gently adjusting your position to help stop it. And now with the new pod blanket, that same intelligent temperature control extends across your entire body. It's like sleeping in a cocoon that actively helps you recover. This is hands down one of the best investments I've ever made for my health. Head to 8sleep.com/theproof and use the code THEPROOF to get $350 off your Pod 5 Ultra. And you've got 30 days to try it. And if you don't like it, which I can't see happening, send it back for a full refund. Shipping to many countries worldwide. See details at 8sleep.com/theproof. On what you said earlier about low cholesterol not having side effects, not being something that people need to worry about, Dr. Thomas Dayspring explained quite beautifully in one of my previous episodes with him that except in very, very rare circumstances, our cells don't actually receive cholesterol from blood. They actually make all the cholesterol they need. And that's a fact that is very reassuring for someone who's actively lowered their cholesterol with dietary changes and or medications.
Yeah, I would very much agree with that whole construct. These are different pools of cholesterol. You know, our cells do need cholesterol to make cell membranes. We need cholesterol for steroidogenesis. We need cholesterol in our brains. But the circulating pool of cholesterol, which is really what we're trying to address in terms of prevention, is a different pool needed from the pool related to homeostasis. Now, you mentioned that cholesterol is made by the liver. I think a really important concept for your listeners is that we often equate cholesterol to what we eat. You know, our cholesterol is high because of the foods that we eat. Part of our cholesterol is determined by our diet and dietary pattern. However, we synthesize cholesterol, we recirculate cholesterol, and we can come back to the example of people living with familial hypercholesterolemia. You know, these are people born with very high cholesterol levels. Genetically, it's autosomal dominant. If you have familial hypercholesterolemia, it can be detected at an early age in childhood, really at birth. You cannot change your diet enough if you're living with a genetic cholesterol disorder to reduce your cholesterol enough to protect you from heart disease. And often people living with genetic cholesterol disorders are told, you know, eat better, exercise more. We'll check your cholesterol next year. So awareness of that genetic risk, in addition to the environment, behavior, exposome, I think is really important for part of the population. The lipoprotein little a is this really incredible story that's been playing out for 6 decades. And we're at the point in time right now where science is moving into not only a better understanding of risk, but the potential to address lipoprotein little a related risk. LP little a, coming back to the ApoB, the center of the LP little a molecule is ApoB. It's an ApoB containing particle, more readily oxidized. But it is the triple threat because it promotes atherogenesis. It also causes inflammation, but there's a tail at the end of the ApoB molecule with these little squiggles or repeats. And these are called kringles. And kringles, if you're not aware, comes from a Danish pastry. These little repeats look like a Danish pastry, which may not be very heart healthy. I've never had a kringle. But the tail of the LP-little-a molecule has structural homology to circulating plasminogen. What does that mean in English? It fools our intrinsic blood thinning system. And as opposed to thinning the blood, it promotes clotting. So it's this triple threat. 1 out of every 5 people worldwide are living with an elevated lipoprotein little a. And we know from data in the US and beyond, the UK Biobank, that 1% or less of adults have ever had their lipoprotein(a) measured, and even a very small amount of people already living with heart disease. I don't know do you know if your dad has an elevated Lp(a)? Because at age 41 with a cardiac event, I would want to take a very detailed family history, dig into traditional cardiac risk factors, also better understand what we call risk-enhancing factors. These are factors that can increase our cardiac risk that many times we're not aware of, clinically. Chronic inflammatory diseases, lupus, psoriasis, rheumatoid arthritis, inflammatory bowel disease, certain races and ethnicities that have a greater chance of cardiometabolic risk, a high lipoprotein(a). We see higher rates of high Lp(a) in people of African ancestry, South Asian ancestry. So, do you know if your dad had an Lp(a) measured?
He didn't at the time. He has subsequently in like the last 2 or 3 years, and fortunately it's very low. And I had mine measured and also towards zero, some very small numbers. So that was great. In speaking to him though, about his heart attack and the kind of prognosis and the medications he was prescribed after that event. And I should say, like, since that event, although he had an event, he's been living, very healthy without any cardiovascular symptoms since then. So
that is great. How old is your dad now?
My dad's 70, nearly 70. Yeah. So he had undiagnosed hypertension and had high cholesterol at the time of having his heart attack. And those are the main two symptoms or risk factors, I should say, that he's aware of.
You know how high his cholesterol was before medicines?
We don't know that, and I've tried to dig into that, and just due to poor records and memories, I'd be lying, and if I was to give you a number there. But what I can tell you about myself is, because I do have my records. So in my early 20s, when I was eating a typical Australian diet, and I'd say I was eating a diet that was based around whole or minimally processed food. So I wasn't the type of person going to McDonald's or Hungry Jack's and eating a lot of packaged foods. I was eating more of a paleo style diet. I was in the fitness, football kind of environments. And that did involve a lot of steak and butter and, nowhere near enough vegetables. Although at the time I didn't realize that. And my LDL, because back then I wasn't measuring ApoB, was between 120 and 130.
Okay. So your LDL was average. And what we often misconstrue is that average is not healthy. Average cholesterol is not healthy. Average blood pressure is not healthy. So digging into the people that we see with established heart and vascular disease, the majority of them have this average LDL or even an average ApoB because they have the necessary amounts of LDL cholesterol to promote atherogenesis. Great to hear that your dad's doing well at almost 70. One of the joys of being a preventive cardiologist is I say that I get to see miracles every day. Because a number of decades ago, when my grandfather had a cardiac event, we had little that we could do to treat the disease, let alone focus on, secondary prevention. But I not uncommonly see people in the office who are 90 years and beyond. And I know that a number of decades ago, these people likely would have succumbed to some type of a vascular event. But today, many of them, there are many factors that go into this, but many of them can live a healthy life for decades beyond. So I often tell my patients we sign a contract to age 100. We just renew 1 year at a time.
Coming back to that cardiac risk assessment, which I believe you said should be done at least from you're around 20 years of age. And then was it every 5 years?
Yeah. At age 20, we should do a cardiac risk assessment for all adults at least once every 5 years. But that risk assessment should start earlier in children where we know their families have early heart and vascular disease, premature disease, or in families where we think there might be some type of a genetic predisposition to early heart disease.
Can you just walk us through, and no doubt we've stepped over a few of the things, but what does that cardiac risk assessment actually entail? If I came to see you and I was 20 years old, what am I going to be measuring and what are you going to be walking me through?
Yeah, the concept of risk assessment is a starting point. We often misunderstand that it's the beginning of a longitudinal process of heart disease prevention. When we use a risk assessment tool, we can say Framingham, the pooled cohort equation, there's a Reynolds risk score, there's a MESA risk score that incorporates coronary calcium. But let's talk about the prevent risk score. This is a score that's been developed for populations. And what we want to do is begin to assess risk, but then apply that risk to an individual. And there's a great way of thinking about this framework that Donald Lloyd-Jones, who is one of the pioneers in heart disease prevention, he had been at Northwestern until recently, is now the director of the Framingham program in Boston. But he talks about CPR. When we do risk assessment, we want to start with CPR so we can avoid CPR. CPR stands for calculate. So that's that risk assessment tool. Personalize. And then the R is reclassification of risk. So the calculation piece would be using a risk score, and that usually brings in demographic factors, age, and gender. And in a risk score, age drives the bus. But age alone, as we talked about earlier, doesn't cause atherosclerosis. Age is just the measure of exposure over time. So age, gender, traditional risk factors. And then in the risk score, we use a C statistic. It's a statistical way of assessing risk. And we also try to check as we're building these risk scores whether adding other factors would improve that ability to assess risk. Because more and more, there's many things we can measure. We can measure metabolomics, proteomics, genomics, the exposome, and we have to ask ourselves when we start with that initial risk score, would adding these factors on a population level predict risk better? And it's often a very tight number of risk factors that allow us that initial risk assessment. So we assess risk, and then we are able to conceptualize that risk or communicate that risk in a 10-year risk score. And that 10-year risk score, let's just say for an individual, they're 50 years old, we might tell them their 10-year risk is 7.5% in the next 10 years of a cardiac event, a heart attack, stroke, or cardiac event. That might sound kind of low. And that person might say, well, 7.5%, well, that's 92.5%. I'm not going to have a heart problem. I'm going to take those odds. But then we're also able to calculate a 30-year risk or lifetime risk. And this is where the conversation deepens. Because in patient-partnered care, and I always say, the patient gets more votes than me, but we're focused on together understanding risk, addressing risk, and optimizing risk. So when we talk about a 10-year risk of 7.5% intermediate, we come back and have that discussion extend to say, but your lifetime risk or 30-year risk is 50%. That's flipping a coin, right? Heads, you're going to have a heart attack. Tails, you're not. So all of a sudden, the listening changes and the activating changes and the game plan changes. So that's the calculate. Then we personalize the CP. Personalization means this is where we start asking a detailed family history. And for you, Simon, although I know you're very health focused, healthy lifestyle behaviors, that's really to your advantage. You have probably most, if not all of those life's essential 8 elements that most people at your young age don't have. However, the personalization is learning about your dad's history and other family members, asking about whether you have potential cardiovascular risk enhancing factors. And then as we move to the CPR, the reclassification of risk, is we have tools today that are not just experimental tools or research tools, but tools where we can understand what's happening to the arteries across the life course. And one of the best of these is the cardiac CT calcium score. I was one of the first physicians trained in this way back when there were only 4 heart CT scanners in the world. And we know now that in the right person, because there can be the wrong person in which to do a cardiac CT calcium score, but in that person who's at intermediate risk, sometimes low to intermediate risk with that family history or risk enhancing factors, we, through a simple test without contrast, without an IV, several breath holds, can look for calcification, which actually occurs beneath the arterial wall as a marker of vascular disease, not just risk. So risk is a mathematical concept. Disease is anatomical. And in an ideal world, we'd want to know all of that. We'd want to know all the risk factors. We'd want to understand anatomy, physiology, function, and we'd want to understand biology. What's going on from an inflammatory status and what's happening with the person on a cellular basis, because atherosclerosis, waxes and wanes, and often there are asymptomatic plaque ruptures. So the CPR, that risk reclassification, in some people, if you have a cardiac CT calcium score of 0, it can help de-risk them, but can never completely reduce risk mathematically. In an individual who's intermediate risk and they have a calcium score that puts them at higher risk, because we always look at that score related to age, gender, and ethnicity. So in a 50-year-old woman, if their calcium score is 5, that can be a high calcium score because along the timeline of atherosclerosis, they've moved beyond the fatty streak, the subclinical soft plaque. And now that response to injury and inflammation is causing a regulated process, laying down calcium in the arterial wall.
Do you ever find a coronary artery calcium score of 0 can give false reassurance, particularly to a younger person, someone that's, say, 40 years or younger?
Whenever we order a test in medicine, we must look before we leap. We need to understand why we're ordering a test, what the information from that test will help us understand about that person's risk, and what decisions might we make with the results of that test. I mentioned that when we do a cardiac CT calcium score, we should think about doing that in the right person. And sometimes you can be too young to have calcified plaque, and that calcium score of 0 might be providing false reassurance, but a lot of it is also understanding what that test is measuring. So if you do have calcification at a young age, it's already a marker of risk. But especially in younger women, we often see calcium scores of 0. But if we follow that person over time, you can transition from a 0 to greater than 0. So it's about understanding the test and the limitations of the test. In medicine, there are no tests that are 100% sensitive and 100% specific. So in a conversation with a patient about a calcium score of 0, I will often provide the good news. And I'm not a golfer, I'm a mini golfer, a putt-putt golfer, but I say you want your golf score to be low and your coronary calcium score to be low. So when your calcium score is 0, I say this is great news. There's no calcified atherosclerosis detectable, but this does not mean you don't have atherosclerosis. The negative predictive value in an asymptomatic person, that's an important caveat, because if you're having symptoms with a calcium score of 0, you're still at risk for events. And anecdotally over the years, because I've done this for decades now, I've had patients with calcium scores of 0 go on to have coronary bypass surgery. And I've had patients with calcium scores of 0 that have been followed longitudinally. And, suddenly 0 goes to much greater than 0. So in science and in medicine, we talk about evidence, but that evidence doesn't always fit individuals. So we still wouldn't, although we might talk about the good negative predictive value of a score of 0 and the less likelihood of an event, it wouldn't make us take our foot completely off the gas pedal of prevention.
Right, but in terms of being good news, a coronary artery calcium score of 0 for a 70 or 80-year-old is really, really good news. And for a 40-year-old, while still good news, perhaps doesn't mean, as much when it comes to whether or not they have atherosclerosis and what their risk is.
So certainly if you're 70, 80, or 90 and your coronary calcium score is 0, that's pretty terrific news. Now, it doesn't still mean that you don't have atherosclerosis. If we look hard enough in most people, not all people, by the way, just like there are risk factors, there are protective factors, resilience factors. And some of these resilience factors are societal, some of them are cultural, some of them are dietary, but some of these resilience factors are genetic. There can be people that have a cholesterol level of 300 and they don't get atherosclerosis. So we need to learn from those people, just like there's some people that can smoke 2 packs a day of cigarettes for many years and they don't get cancer or other diseases associated with tobacco use. The calcium score, though, is one measure of atherosclerosis focused on the heart. We are beginning now to look at pragmatic, opportunistic utilization of imaging in heart disease prevention through machine learning, big data, health system approaches. There are many people that have had CTs of their chest related to non-cardiac reasons. It's about 19 million people a year in the US. And not uncommonly, the chest CT might be done because of some other reason, lung cancer screening or, a car accident. And we similarly do screening CTs of, not screening, but clinical CTs of the belly and the brain. We now can harness that data that is in the electronic medical record. And frequently the patients are told, your CT looks great, nothing acute, but failed to mention that there was moderate atherosclerosis detected in the aorta, in the belly, or even evidence of small vessel white matter disease of the brain, which is repeated microvascular insults to the brain, putting people at risk for dementia. So we are now at the stage where we can harness a lot of this data. We can bring it to that clinician-patient risk discussion, and the ability to detect people at high cardiovascular risk who are unaware and their clinicians are unaware provides us with another opportunity for prevention.
So in your view, when should someone get a CT angiogram versus a coronary artery calcium scan?
Comes back to the question of how will additional data help that person and their clinical team focus on prevention. The CT calcium score is non-contrast, breath hold, and provides us with some information of risk, but as you discussed earlier, doesn't pick up non-calcified plaque. Just like we've evolved now over decades of understanding cardiac risk, the parallel evolution of cardiac imaging is at a really critical point now. We've often been asked, okay, these are my risk factors, I got that. Here's my calcium score of 0. I got that. That's good news. Good news for now, but I'm still young and there's a family history of heart disease and I have some borderline risk factors, and we're trying to make some decisions about that plant-based whole food dietary pattern, staying away from the ketogenic dietary pattern, moderate regular physical activity, and then of course, trying to do all we can to focus on extending that Healthspan, Life's Essential 8. But the big question is, do I have atherosclerosis even with a calcium score of 0? We are finally at the place in time where we can begin to do this clinically. It's very much been a research tool. In research, we've measured the carotid intima media thickness, the thickness of the wall, the artery in the neck. That's really a population-based tool. We've been able to measure the plaque volume in the body through 3D ultrasound, but we are at the point in time where we can use coronary CT angiogram, where we slow the heart down, we put it in IV, and through using contrast, we can take a picture as opposed to the donut or the bagel. We now take a picture of the donut and bagel hole and the wall because the disease is happening at that interface. And we can look to see if there is plaque, where is the plaque, the volume of plaque, but also the composition of plaque. And we can also do this now at expenses that are, still significant for out-of-pocket pay. Coming back to what you mentioned earlier about privilege. Everybody who's an middle-aged adult American, doesn't have the ability to get their own cardiac CT or CCTA. The CT calcium score out of pocket, because it's still often not covered by insurance, can be $100 or $150 or $200. The CCTA, we're talking about, hundreds or even, thousands of dollars. It does tell us, though, whether there is atherosclerosis, not just calcified atherosclerosis. Where this gets really exciting is we've talked for years about regression of disease, limiting progression, and turning the light switch off. We think we're at the point in time where we can do this longitudinally, following a person, probably not every year, but in that stable person where we're addressing their risk factors through a combination of lifestyle and behavioral approaches, through modification of risk factors and pharmacotherapies. We can probably reassess in 5 years and be able to tell somebody the plaque composition has stabilized. And that likely will be a predictor of a reduced likelihood of cardiovascular events. We are gathering data now to better understand how to use this clinically, a CCTA, not just in a person who's in the emergency room with chest pain, but to use that tool for preemptive, more personalized cardiovascular disease prevention.
I am absolutely excited to share an exclusive offer with the Proof community. This is a limited time offer just for my audience, and no doctor referral is needed. Function Health is a comprehensive at-home blood testing service that gives you access to over 100 biomarkers, covering everything from heart, liver, kidney, and metabolic health to hormone levels, inflammation, and nutrient status. That, my friends, is 5 times more testing than the average physical. I chose Function for my own blood work and to be a sponsor of this show because they are the best in the world when it comes to helping you understand and own your health. It's true, the depth and quality of their testing is unrivaled. And as regular listeners of this show will know, you cannot optimize what you don't measure. Don't guess, test. Use Function to know exactly where your health is today, and then intervene with evidence-based medicine and lifestyle changes to feel your best and reduce your risk of chronic disease. With Function, you get access to very important markers like Lp(a), a genetically driven cardiovascular risk factor, ApoB, the most predictive marker of atherosclerosis, and LH and FSH, reproductive hormones typically missing from standard lab panels. It's not uncommon for these biomarkers and others to be elevated. For example, over 50% of Function members have an ApoB level, and over 20% have an Lp(a) level that is above the optimal range. You can even add on harder to access tests like cystatin C, a very sensitive marker of kidney function, as well as selenium and iodine, nutrients that are essential for thyroid and overall health, yet rarely tested. So what are you waiting for? Run over to functionhealth.com/Simon Hill today and be one of 1,000 listeners to score a $100 credit. That's functionhealth.com/Simon Hill. Yeah, I think outside of the cost, feedback I've had from certain people is reluctance to get this testing done in the event that they have a positive finding. Would that affect their health insurance?
Wow. So it is a really important question. Of course, anything done, and I'm not an expert in this, by the way, as a clarification, but anything done under the auspices of your doctor or within the realm of clinical medicine, once that is documented on the medical record, that can't be undone. So would you be rated on your insurance for having now a diagnosis of atherosclerosis? I am very specific about what I call atherosclerosis when I'm seeing a patient. I don't call it cardiovascular disease, and I don't call it heart disease. I call it subclinical atherosclerosis. And if we're looking for subclinical atherosclerosis, if we look hard enough, is present in many, depending upon the age, many teenagers, many young adults, clearly many, if not most, middle-aged individuals. These are areas we need to better understand, but from a risk assessment standpoint, if that CCTA did not change our game plan, then more information isn't always better. And we want to be very, very careful about having one test lead to additional tests that can be harmful. In medicine and science, more information is not always better. We often, if we did a barrage of tests, biomarkers, it's likely that one or more biomarkers will be out of range. And if we start chasing the biomarker instead of understanding the totality of that individual, we can do harm. Similarly, I've had patients come to me for a third opinion or fourth opinion or fifth opinion where they were a healthy person. It was their 60th birthday. They went ahead and got a cardiac CT calcium score. They had a lot of calcium. They were doing well, but the CT calcium score back then led to a heart catheterization. Now it might lead to a coronary CCTA. And then, there's a plaque seen that might be borderline significant. And they're down this path now of trying to fix blockages. And mechanical procedures are not going to treat the disease of atherosclerosis. They're going to be a plumbing procedure where we address a focal plaque, but not the complete disease. So I do think for your listeners who've raised some questions about should they get a CCTA, here I'd say have a really important conversation with your doctor and discuss your cardiac risk in depth, discuss your goals and your goals of care, but also raise the questions of, is there potential harm? These scans are done with contrast. Now we do them with less contrast, with less radiation, but there still is some potential harm for a contrast reaction. And although the radiation now is at the level of a mammogram for one of these tests, cumulative radiation, especially if you're getting radiation at a younger age and many radiation doses over time, can increase the risk of many diseases, including vascular diseases.
Yeah, that's important for people to consider as well. You mentioned there that you don't diagnose someone with heart disease if they come back with plaque necessarily, and that often you write down that it's subclinical atherosclerosis. Is the distinction between subclinical atherosclerosis and heart disease or atherosclerotic heart disease the symptoms piece?
It's the overt disease, and it's really a continuum. There are some people who are primary prevention patients with risk factors that may have a lot of subclinical atherosclerosis and higher risk than somebody that's already had a heart attack. And now we're addressing that risk comprehensively, and the disease has quieted down. That switch has maybe not completely turned off, but the rheostat has dialed down from 100 to 10. So there's a spectrum of risk, and then these bell curve distributions overlap. But at least clinically, for the chart, the overt heart disease or cardiovascular disease occurs, yes, symptoms, but an event, a heart attack, a stroke, manifest peripheral arterial disease, a bypass surgery, a stent. And I'm very cautious as I'm communicating to the medical record and trying to be as accurate as possible because I think it's important. And it's not just an insurance issue.
The other scenario where I think this gets interesting, and this literally came up yesterday, I was at a lunch and I was talking to the girl who was seated next to me. This was at an event, and I'd say she was mid to late 30s. And she was talking about how she had high cholesterol, and her physician recommended that she started taking a statin, so lipid-lowering medications. And she had some resistance around this, and I didn't get into that conversation. I felt like that was for another day and really for her and her physician to discuss. But interestingly, she said that she was getting a Clearly Health scan and was going to then use those results to make a decision as to whether or not she should take a statin. What do you think about that kind of decision-making process? Are there any holes in that, or what would, if you were her cardiologist, what would you want her to be, considering in that process?
Yeah, first I would do some listening. I say, when in doubt, listen to the patient. What are their questions? What are their concerns? Then, before ordering a test like that, a CCTA, which, we can do. We can look at plaque volume composition. We can also look at flow non-invasively, a CCTA FFR, fractional flow reserve. So we can measure both anatomy, state of disease, and also physiology to some degree. We can't always measure plaque activity directly, but we can look at the different forms of plaque. And we know there is some plaque that's higher risk than others. For this woman, though, I'd want to know, how old are you? And tell me more about your family history. And let's go through that CPR a little bit. At least start out calculating her risk, personalize it, because she's already jumping to the R, the reclassification of risk, before she does the C and the P. So I'd want to have that discussion after the C and the P, and also talk about goals of care. Whether it's a statin or other decision about a pharmacotherapeutic agent, for each and every agent, we should understand the indications, the contraindications, the benefits, the risks, and the side effects. We often don't put into the equation the risks of not using medications. So let's just talk about a statin for a second. If this woman, one of her goals is promoting heart health, well, certainly all for that. For better understanding her risk, want to be supportive of that. If she had no evidence of atherosclerosis, zero, well, depends on what her risk factors are, to be honest. If her LDL cholesterol was 275 milligrams per deciliter, and there was early heart disease in her family, and high cholesterol runs in her family, there's a simple equation. F plus H should make us suspect familial hypercholesterolemia. So that statin might not be to treat her risk today or tomorrow, maybe not in the next 10 years, but we should have a team decision about lifetime risk and goals of care. But now let's just say, for argument's sake, she has this average LDL. That is not normal, it's average. We certainly might not want to start pharmacotherapy at an early point in time, because she may fall into a healthy group overall. But I'd want to have an educated and informed decision before we leap into the imaging first approach. And if we still had that question mark together after going through a comprehensive risk assessment, a personalized discussion about risk, and then a discussion about goals of care and medications versus no medications, coronary CCTA, could be an okay next step, recognizing the potential, risks of taking that plunge, although quite low.
We've mentioned a couple of times here that normal LDL cholesterol and normal blood pressure is not optimal. What is the optimal LDL cholesterol, blood pressure for the general population who is wanting to prevent cardiovascular disease as early in life as possible? What would you have told me to aim for if you had have spoken to me at age 15 or 20?
Optimal for LDL cholesterol for the general population, we'd have to start saying probably under 70 milligrams per deciliter or lower. Why do I even pick that number? It's because the number of less than 70 milligrams per deciliter, at least by studies done within the arteries, intravascular ultrasound, it's the splay point where we know that the disease begins to regress and the progression slows down. Now, from, again, realizing that's at age 20 or 30, we might not be able to undo the first 20 or 30 years of your life. And if the disease, atherosclerosis, has already started, we absolutely want to optimize your cardiac risk profile with lifestyle behavioral approaches so that LDL below 70, and LDL below 70 is a pretty tough hurdle for human beings. Through lifestyle and behavioral approaches only, even if they're vegan or vegetarian, because our cholesterol levels are not only determined by what we eat. Exercise has very minimal impact on the LDL cholesterol. It can raise the HDL, lower the triglycerides. Let's talk about blood pressure. Your blood pressure optimal is less than 120 over 80 millimeters of mercury. And most adult Americans do not have optimal blood pressure. It's typically young women who have optimal blood pressure, but many are in the already elevated blood pressure before they get to hypertension. From the Framingham Heart Study, we know even in that window between optimal and elevated, if you're living in that window for decades, it doubles your cardiac risk.
And what are the main risk factors that are driving that elevation in blood pressure?
100% of human beings carry the genes for hypertension. 90% of Americans will develop hypertension if they live long enough, and it is not a normal consequence of aging. 100% of humans have the genes because once upon a time, we didn't have abundance of food and we didn't have abundance of water. And so these genes were survival genes. You may have heard the concept of the thrifty genes. Populations that have been most recently exposed to starvation or famine often have higher rates of thrifty genes, and these can be the genes for prediabetes as well. What happens is you take those genes for hypertension and you place them into the modern environments that now are not only occurring in Western society, but are occurring in low and middle income countries as we are importing processed non-nutritious foods. And we're also translating unhealthy behavioral approaches, sedentary behavior, secondary tobacco use or primary tobacco use. And then we talked about some environmental factors. So we add those genes, and sometimes just gaining 5 pounds or becoming sedentary can begin activating those genes. Now you're not in the optimal blood pressure category anymore. You're now living with elevated blood pressure. And even if you're seeing a physician regularly, in the office, your blood pressure is, it's borderline or it's mildly elevated. Let's keep an eye on it. Let's work on your exercise more, physical activity, your weight, your diet, a DASH type dietary pattern, which has been shown to lower blood pressure. But over years of elevated blood pressure and the impact on blood vessels, both large and small, risk for vascular disease goes up over time. The blood pressure, the cholesterol, and then triglycerides, we haven't talked a whole lot about that, but our triglycerides are ambient cholesterol floating in and around our blood. And if each and every one of us, let's just say you and I had lunch together today, we ordered the same exact thing for lunch, but we started measuring post-lunch both our blood glucose and our triglycerides. There'll be a curve for each one of us of what happens to the glucose levels, the triglyceride levels, and that's determined by genetics. It might be determined by our physical activity, our weight. And for each and every one of us, if the blood glucose and triglyceride levels stay elevated for hours after each meal, and then they come back down, and then we eat again, and they go up and stay elevated for hours and come back down, this is risk over time. And we often miss that risk because when you go to your doctor, you might get a a fasting blood glucose, or even an A1C, which determines your mean glucose over the last 3 months. So we do have tools today where we don't have a triglyceride meter. It might be interesting if we had one to show what happens when we have a healthy pasta meal, maybe a glass of wine, and a good serving of vegetables and fruits. We think we're doing a good job. But we do have CGMs today, continuous glucose monitoring, which are approved for people living with diabetes. These CGM monitors, though, although they're not perfect, and they're not approved for people with prediabetes, they can be instructive tools to help us better understand the interaction between us and our food environment and our physical activity. And it can sharpen the edge on trying to improve lifestyle and behavioral approaches. The elevated triglycerides over time, it's taken us longer to understand the risk of triglycerides. But we think now clearly having repeated elevations of triglycerides or even a modestly elevated fasting triglyceride level. So coming back to optimal, you'd want your fasting triglycerides to be less than 100 milligrams per deciliter. That's pretty low. And then you'd want your weight to be optimal. It comes back to those life's essential eights and the biologic factors that are determinants of cardiovascular health, not cardiovascular disease.
Given the effect that body weight or excessive body weight has on post-meal blood lipids, on postprandial blood glucose, on blood pressure, all of these risk factors for vascular dysfunction, what do we understand about GLP-1 agonists and their effect on cardiovascular disease risk?
It's more than just the excessive weight, it's where we're carrying the weight. We know that subcutaneous fat, although not healthy, there's still, at least in my opinion, no metabolically healthy obesity over the life course. But when you have fat that is visceral fat that is detectable only through scanners around the pericardium of the heart, fat that's encasing our organs, this visceral fat is very active. It's not inert, and very active related to inflammation, increasing the risk of thrombosis or blood clotting, and those cytokines that are part of the atherosclerotic process are being upregulated with sometimes in people just a small amount of visceral fat. We call this skinny fat. There's some populations where outwardly they might be skinny and their waist circumference might be borderline or even, quote, normal, but a little bit of excessive visceral fat changes their genetic signaling. The GLP-1 receptor agonists are a phenomenal class of medications. They were initially studied as a drug to treat diabetes, but because the FDA mandates that all diabetes drugs have proven cardiovascular disease safety in addition to the ability to treat diabetes, we've learned some really exciting things about some of these medications that, in addition to being safe from a cardiovascular standpoint, the GLP-1 receptor agonists and the SGLT2 inhibitors appear to have cardiovascular disease protective effects. The GLP-1 receptor agonists, boy, if you're out there in any platform, you're hearing about these all the time. They were developed as diabetes drugs. They now are very impactful drugs to help people lose weight, but we also want to not just lose weight. We have to focus on weight maintenance. And if these drugs are stopped without the appropriate architecture of how they are started in a stepwise fashion, and how weight maintenance is built from a learning standpoint and a change in behavior and change in food environment, people will gain weight quickly when they stop these agents. They, though, beyond the diabetes, treatment, prevention, and the weight loss piece, these drugs appear to prevent cardiovascular disease. In fact, a study published about a year ago now in the New England Journal of Medicine, the SELECT study, looked at people with obesity and heart disease. They didn't even have diabetes. And these drugs reduced the likelihood of a composite of cardiovascular events. Right now, there's a lot of interest and excitement in these drugs. There are access issues. I hear from people all the time, that they're on them and then they're off them because they can't get these drugs. You want to be very careful because these drugs are being made in unscrupulous compounding pharmacies. So you want to be sure you're getting what is the drug and not additives and beyond the drug. And then the important thing is we come back to the public health piece that we started talking about earlier on, is that the GLP-1 receptor agonist, and I'm intentionally not using a specific drug by name here because the classes of these drugs are now agents that act by 2 different mechanisms, studying drugs by 3 different mechanisms, so extending the weight loss possibilities on and on and on. These medications will not be the cure for cardiovascular disease or diabetes. If we wait to treat later in time, we can make a significant difference for the individual, even for the population. But we will be in this vicious circle of creating obesity, treating obesity, pre-diabetes, diabetes, and cardiovascular risk. And then we'll create another generation where we treat, hopefully do better, prevent. So we must come back to the upstream prevention and investment in public health, not just an understanding of the power of public health, but the importance of public health in changing the health ecosystem. And this ecosystem has changed significantly for the past 100 years. We have the capabilities of undoing the changes we've made, but that has to be done with intent, with strategy, and investment.
Yeah, I love how you approach that because often the GLP-1 agonist discussion falls to this kind of either or thinking. And what you're saying makes a lot of sense. At the individual level, they can be very, very beneficial. And we should be extremely excited and proud of science and the fact that these are available, although it would be great if they were even more available. And at the same time, be putting a lot of energy and thought and strategy into going upstream and thinking about how do we prevent people from becoming overweight, obese, developing cardiovascular disease in the first place.
Yeah, small changes in caloric mathematics over time can add to overweight and obesity across the life span. More and more, we will have designer pharmacotherapeutic agents. Lp(a), for instance, we now have antisense therapy, small interfering RNA, where we can prevent the message from being developed to the injurious protein or lipoprotein here. But the real gaps we have today are in the implementation science. The science will continue to charge ahead. Our scientific understanding will charge ahead. I often say if we had a whiteboard and we just erased where we were right now, let's just start all over again. And for the next 5 years, we shouldn't do this, but let's just say for a discussion point, we will do this. We're going to press the pause button on scientific discovery for the next 5 years. And now we're going to invest our efforts in implementing all we know at a population level, a public health level, a global level that will translate to individuals, families, and communities. We likely will do more good in the next 5 years doing that than advancing the science. Now, we'll take our finger off the pause button because we want science to advance. But the real gaps we have today, and for your listeners who are thinking about them as individuals, the concept of One Health means that we all live on this planet together, and planetary health affects each and every one of us. And so, although an individual listener is improving their health and their health span, when others on this planet are vulnerable, we all remain vulnerable.
If you had the presidency for 5 minutes, what policies would you ask for that you believe would have the biggest impact on reducing heart attacks and strokes in America?
Anyway, I can have it more than 5 minutes, maybe for a couple of years or so. But we'll go back to 5 minutes. In those 5 minutes, where is cardiovascular disease beginning? We need to invest in maternal health because health begins before birth. We need to invest in healthier food environments. And we often use it's not an excuse, but we often use it costs more money to eat healthy. But we can create either through incentives or subsidization where we know where there are food deserts, or even worse, there are food swamps. No access to healthy foods, poor access to transportation. We can bring healthy food to these communities, and there's a lot of waste. So that healthy food might be helping planetary health as well, because as opposed to wasting food, we can reutilize food that would have not been eaten by people. And then coming back to a plant-based whole food approach, how we use our green earth is very important to health in general. The last thing there would be an investment in our children. From a policy standpoint, when I went to school in New York, public school, we had PE, and it was every day. And in the middle of the day, you put on your PE clothes, you got sweaty, and you know what? Like, everybody was sweaty. That was okay. And then you went about the rest of your day. And so one of the biggest challenges today is not just lack of physical activity, let alone exercise, high intensity interval training, resistance training, all the things people want to do to become even, more in tune with their VO2 max and musculature. But we need to help people at a young age be less sedentary through bringing back healthy opportunities in the schools, in the workplace, and also healthy opportunities to get off social media, screen time. In Japan, our oldest son right now, Matthew's on his honeymoon in Japan. And from a societal standpoint, having organization and policies can often create that making the healthy choice the easy choice. Let's just say we're desk workers, we're on the computer. Each hour for 5 minutes, if it is encouraged that we stand, we stretch, we do some physical activity, in an 8-hour workday, that will be 40 minutes of physical activity without having to, quote, exercise. And in Japan, my wife, who's an internal medicine physician, she and I often will take healthy walks through the forest. In Japanese, this is called Shinrin-yoku. And if you look at the scientific literature, forest bathing has protective effects on many levels.
Glad to hear that from a cardiologist. There you go, doctor's order. Let's land the plane here, and I definitely need to convince you to come back on because I want to spend a lot more time on the intervention side of things and loads of questions about diet and more on exercise and environmental exposures, things that we've kind of touched at a surface level, but I think we can double click on in a future episode. Leave us with something personal. What's one daily habit as a preventive cardiologist that you personally never skip or rarely skip, something that for you feels very essential to heart health and longevity?
Yeah, so let's land a plane. Let's land it safely. On an individual level, I've always been a dedicated exerciser. Used to be a basketball player, didn't get drafted in the NBA, so my backup plan was the preventive cardiologist. I had been a marathon runner, and on the next episode, we should talk about, can you over-exercise? Because I remember we discussed that in our prep for today, so let's table that one. But even in a day when I don't, quote, exercise, because there's a difference between, first of all, first goal is be less sedentary, sit less, move more. Then increase physical activity, because just the concept of exercise can be a barrier to some. Even on a busy day for me, my day is to get 10,000 steps cumulatively. I'm very low tech. I needed help today getting set up for the podcast from our Emory tech, and my wife just making sure I was at the right place at the right time. But I keep a step count on my phone that I have with me all the time. And I have it with me even when I'm working in the house on the computer. And it makes me cognizant that I need to move more. And by the end of every day, whether it's a break when I'm not on the computer, walking with my wife and the dog, or whether it's a day when I'm out for a run, or, cycling, it's interesting. You can keep your cycling, I guess, tabs on your cycling, but somehow you get some extra steps if you have your phone in your pocket when you're cycling. But so that physical activity is really important to me, not only physically, mentally, emotionally, spiritually. And the last thing I'll leave you with is the concept of active rest. So our lives are frenetic. Stress, anxiety, and depression is as powerful as a risk factor as type 2 diabetes. We didn't touch upon that today, but I'll come back for another one. Hopefully I'll visit you in California because we can visit Matthew there who lives in LA. But
that'd be great.
Yeah, our younger son, Daniel, and I are good at pressing the active rest button. So whether it's fishing or walking or shooting basketball or sometimes painting, what can you do to press that pause button where you're more present, totally focused on the world in front of you, but not the world around you? That we know can really help your health in general and help your vascular health. And just like risk factors exert risk over time, making that a habit can have protective benefits over time.
Yeah, I'm glad you mentioned that because you can have the diet and the exercise dialed in, but still be extremely stressed and anxious. So it's an important reminder for all of us. Dr. Sperling, thank you so much for your time today and the incredible depth of information and knowledge that you shared with us, the work that you do and all of this information that you've shared. It quite literally saves lives. So I'm really grateful that we had the opportunity to connect with you and help share your message here. And as I mentioned, I would love to have a follow-up episode and double click on many of the things that we discussed today.
Thanks again for the invitation. Grateful to join you and your podcast listeners out there. And until we meet again, hopefully in California.
Done deal. Thank you very much.
Or maybe Australia.
Yeah, we could do that too.
All righty.
There you have it, friends. I hope you enjoyed this episode. If you did and want to stay up to date with future episodes, be sure to hit that subscribe button on YouTube and follow on Apple or Spotify. Finally, Thank you for showing up and the effort that you're making to take control of your health. I look forward to hanging out with you again in the next episode.